So we now said, no, we can't leave this woman like this. She's hemodynamically unstable, she's bleeding. Let's even do a proctoscopy. If we cannot do a colonoscopy at this time, let's even do a proctoscopy. So we put in the scope, and then, wow, you saw the picture. It was plenty of blood, and it was maroon, dark colored blood coming. And it was like tap, rushing at me like this. I was like, wow. The blood pressures were just going, and you know, that kind of thing, tachycardia and all that. We said, no, this colonoscopy we must do. So we went in with a lot of jet lavage and everything, just looking, and that was how we found that bleeding vessel inside that diverticulum. And it was on the right side, because usually the diverticuli in the right side, they have wide neck. So you have an extensive length of blood vessel in it. That's why they tend to bleed more than the ones on the left. And it's easy to just clip it because you have enough space in that diverticulum to apply a clip. We did it. Everywhere was dry.
Yeah, globalization has helped us in advancing in minimally invasive surgery. These days, we don't have to take patients into theater for what we can do endoscopically. And this also promotes a faster recovery time.
The first case is a 46-year-old financial personnel, Mr. F.A. So he presented to the ER on account of passage of bloody stools of 5 days duration and lightheadedness. So this was noticed while he was playing tennis, and then he realized that he was getting tired, but when he rested, he did a bit better. And then the distribution of the blood, he described it as bright red, copious, associated with passage of clots.
So this is how we think about rectal bleeding. When somebody is bleeding through the anus, in my mind, my question is, how would I first? I'm thinking of the age of the patient. From the age of the patient, we can have an idea of what the likely cause of the bleeding will be. If you have an infant, you are thinking of, I thought the medical student will be echoing it, an infant like 6 months, 4 months, you know, they are thinking of intussusception. In that case, the bleeding is going to be like red currant jelly. Is that not so? And then the next thing you want to do is ultrasound of the abdomen. Is that not so? You do the ultrasound, and then in the right iliac fossa, you find like a sausage-shaped mass, you know. And that's it. And our pediatrics department have been doing very great job. But if you have a child, an older child, say like 5 years, who is bleeding, the first thing that should come to your mind should be like rectal polyps, you know, juvenile polyps, and stick your hand into the anus and you can feel the polyp. You have an older child like 10 years, what is running to your mind? You're thinking of Metzger's diverticulum. That's what you're thinking in the terminal ileum. That's what they usually have. By the time you go to young adults, 20 to 40, you know, then you are thinking of hemorrhoids, inflammatory bowel disease for them and all that. But anyone who is above the age of 40, we always want to rule out cancer as much as possible when you have rectal bleeding. So the next question is, what is the type of your bleeding? I have told us we think of just 2 types, melena, hematochezia, and we already know that if it's melena, it's coming from the top. If it is hematochezia, bright red blood, maroon color, dark, then you know it's colon, all right? Or downstairs, anus, rectum, and all that. The last question we always want to ask is, what is the pattern of the bleeding? And we don't look at just the frequency of the stool alone. We also look at the... So that's why we see that once you are 45 and above, from 45 to 75, you need to be screened. Whether you have a problem, it doesn't matter, just come get screened. We put the scope, many times you don't see anything, we say, Oga, congratulations, come back in 10 years. Some will come, we put the scope, we see the polyp, we take it up right there, and we still say, congratulations. When the result comes and it says it's not cancerous. And for those who are cancer, by the time we tell them it's cancer, we do further investigations to check whether the cancer has metastasized. And if the result comes and says, oh, it has not metastasized, it's just limited to the colon where you took it off, we will take them to theater and cut that part, resect that part, and join the normal part. I will still talk to them and say, congratulations. But those who will not get the congratulations, those who will get only consolation, they are the ones that when we take it and it comes by, it says it has gone everywhere. We have plenty of things that we can do quickly for you. Some can even be done in the office, bam, and you are done. and the bleeding you will no longer see again. The bleeding you see today. Sometimes they will even do colostomy to divert the stools, We only do hysterectomies for complex cases, but straightforward hysterectomy, we don't cut them big and all that. We just use laser to burn the whole thing off. It seals, the patient goes home the same day or the next day. For those other cases, they wait for like 2 weeks in the hospital, and they are still blessing. At the end of the day, they will divert with colostomy. I had a patient like that came from Ife. At the end of the day, it was laser surgery that sorted his problem, and we do that very well. He's bleeding massively, and I told you that, what did we do? We scoped, we saw it, and we stopped the bleeding by just sprinkling, by just spraying hemostatic powder on it. We kept quiet. The patient was very happy, but that was not the end of the story. We asked the patient to come back so that we could take biopsy from the edges of this ulcer, because sometimes cancer of the rectum can masquerade as solitary rectal ulcer. Sometimes inflammatory bowel disease can masquerade as solitary rectal ulcer. It might even be infectious colitis. The only thing, infectious proctitis, the only thing that can make a difference is histology. Many times, some people have constipation and we are looking for the cause. We've done colonoscopy, we didn't find anything. We've done everything, we can't find anything. So what is the problem? There is no polyp, there is no inflammatory bowel disease, there is no diverticular, whatever, nothing. And the patient is still complaining of constipation. And that when I have constipation, I go to the toilet, I poo, there's blood. They are just complaining. Every time they keep coming. Many times this is the problem. There's something called dysynergic defecation. So normally, when you want to poo, your rectum is supposed to be able to relax to allow things to come. One of the continence mechanisms that you have in the body is this muscle called puborectalis. It's a component of which group of muscles? Levator ani. Medical student, what are the other components? Pubococcygeus and iliococcygeus. Excellent. MCQ for free. This is the puborectalis. You can see it attached to the pubic bone, and it's just a U-shaped muscle wrapped around the rectum like that. So usually it pulls it forward when poo is coming, so that you don't poo on yourself. So when poo is coming, this is going to contract and pull it up. Poo will not come until you decide in your mind that you want to do it. So when you decide that you now want to do it voluntarily, it relaxes, and then it brings this. When it relaxes, this will now fall straight, and then the poo can now come. Some people have problems with this muscle. That's why they are having constipation. It's a pelvic floor problem. Because this muscle and those other two that the medical students mentioned are the muscles that hold all the pelvic organs. Your rectum, your bladder, everything is held by those muscles like this so that they don't fall down. You can imagine. There are people who have those organs falling down. The bladder is downstairs, the rectum is downstairs, and they come like that to the hospital. Doctor. I tell you, then you see, wow, what is this? I hope you don't do that, doctor. The pelvic floor is gone. So what do we do for this patient? That's why I brought it up. Because you have checked everywhere, you can't find anything. And this is the problem. How do you detect this problem? So there is one investigation we have not been doing that I think we should be doing. And that is this investigation. It's called defecography. I spoke with Dr. Jeremy and he said we can do it. Dr. Jeremy, since you said we can do it, please tell us how we can get it done in this hospital.
Towards the end, so yeah, you're very much welcome.